say 70-year-old, fell out of bed at night, dislocated the shoulder. The shoulder was put back even in the emergency room and it popped back. That patient actually has a much higher chance of injuring the rotator cuff in addition to injuring the labrum.
Much higher, much higher.
And when you come to surgery with that, again, it's depending on what you see, it's what you have to repair.
Correct.
In the younger individual, generally it's the labrum or the soft tissue, generally in the front because that's a more common type of dislocation.
Absolutely.
That's repaired, but in the older individual, that tear in the rotator cuff can play a major role in how they do.
Absolutely, and I find that patients in their 70s who sustain a rotator cuff tear from a shoulder dislocation are sometimes, it's one of the more difficult problems to treat because it's not that unusual that someone has an asymptomatic rotator cuff tear, i.e. they didn't know they had one, and because it happens slowly over time and there's a lot of redundancy and function around the shoulder, their shoulder works just fine because the neighbors are helping out. And then they sustain a dislocation of their shoulder, they extend that rotator cuff tear traumatically and it becomes something very difficult to treat because oftentimes once we see that on the MRI, it can be classified as an irreparable rotator cuff tear, and I like to call them a non-healable rotator cuff tear because we can probably repair them, but whether or not that tissue is able to heal back on the bone, again, is the rate-limiting factor.
And let's say somebody who is older ends up having a dislocation with a large rotator cuff tear where the muscle tissue is actually atrophied, which
Correct.
means they've had a rotator cuff tear for a while, but now they decompensated.
Correct.
And you go in, even if you try to repair it, and let's say they just don't do as well, what is their chances now? What else can they do?
Well, it depends what their shoulder function is, but if they have what's called pseudoparalysis of their shoulder, meaning they try and lift their shoulder up and all they kind of get is a shoulder shrug, there is a newer and evolving technology of shoulder replacement called reverse shoulder arthroplasty, where instead of putting the ball on the ball and the socket on the socket, we do just the reverse. We put the ball on the socket side, and then you don't necessarily need the rotator cuff to keep the ball centered on the socket because the muscle tension of the deltoids will do that alone. And that can give somebody back the function of being able to raise their hand up, which is important to feed yourself, to bathe, etc.
So essentially changing the socket to the ball and the ball to the socket provides a different moment arm
Absolutely.
to try to compensate for the lack of rotator cuff, but depends greatly on your deltoid muscle, which is this muscle you feel right out here.
Correct. So the deltoid muscle actually has to be working because if it's not, doing a reverse shoulder replacement would be a disaster because there would be nothing to keep it in, so it would just dislocate and you would have made that patient worse than they were to start.
Of course, we always want to make the patient better.
Always better.
And we have to explain to them these are the realistic expectations as well as the risks and benefits of doing, obviously, any type of procedure.
Any type of procedure. That's absolutely true.
Well, thank you very much, Dr. Schachter. I really appreciate your time and your expertise about shoulder injuries. And we covered rotator cuff tears as well as instability and labrum pathology in the younger as well as the older individual. Stay tuned, and we're going to move on to hypertension or high blood pressure, the silent killer. We'll be right back. Welcome back to Healthcare from the Hill. We're going to move on to talk about hypertension or high blood pressure, which many Americans have, but many Americans may not know they have. That's why it's sometimes referred to as the silent killer. We're going to speak to Dr. Michael Rudolph from Milford Hospital, who will talk to us about what is high blood pressure, how do you treat it, when do you treat it, how do you know you have it. Before we move on to that, I'd like to go over just a few things. If we can go to the slides, please. High blood pressure. What is high blood pressure? Essentially, it's increased pressure within your arteries. Now, your body has generally arteries and veins. Arteries is the blood vessels that take the blood away from the heart, and the veins are the blood vessels that bring the blood back to the heart. Once the heart pumps, it causes pressure within the arteries, and this is where high blood pressure can occur. We'll move on to the next slide. So in the blood vessel, there can be thickening depending on what pressure the blood vessel sees, where normal is on the left side and hypertension or higher blood pressure is on the right side. Next slide, please. Well, what type of symptoms can you get if you have high blood pressure? You may not know that you have high blood pressure, but if the pressure goes fairly high, some patients can come with headaches, dizziness, problem with their vision, sometimes nausea, and chest pain or even shortness of breath. Move on to the next slide. Well, what happens within your body if you have high blood pressure? What type of injuries can occur to the organs that you have? Well, heart attack or myocardial infarction, failure of the heart because it has to work harder to maintain a higher pressure, stroke or what we call mini strokes or transient ischemic attack, TIAs. Your kidneys will see increased pressure and can also over time fail. Eye damage with, again, vision problems. Peripheral arterial disease, which is increased damage of your smaller vessels, and outpouching of the aorta or aneurysms, which can be deadly if they do rupture. Next slide. Well, there are a certain amount of patients, which is a smaller percentage, which can end up with what we call malignant hypertension. This is extremely high blood pressure. And in malignant hypertension, this is actually an emergency. People can stroke, hemorrhage, or even die from having such extreme high blood pressure. If we can go to Dr. Rudolph. Dr. Rudolph, thank you very much for giving us the time today.
You're welcome.
And I think this is a very important topic because many patients and many people don't really know what their blood pressure is. And if we even start on what is normal blood pressure?
Right. So people commonly talk about 120 over 80, but it's not just a number. Basically, studies of large populations of people have been done, and I think the Framingham heart study is one that's been going on, I think, 30 years, maybe 40 years, and they see what happens to these people over time, so they can figure out, gee, these people had a blood pressure of 120, systolic, the upper number at a certain age, and what happened to them? Gee, these people had a systolic blood pressure of 130, what happened to them? And it turns out that below 120, you're pretty safe. That's the upper number. And below 80, the bottom number, you're pretty safe. Just to go over some terms which weren't in the slide, most people know this, but 120 over 80 is, the upper number is called systolic, the bottom number is called diastolic. If you can't remember those medical terms, you just say the upper number, the bottom number, and basically when the heart pumps, when that pump happens, the blood pressure goes up in the artery, and then when in between pumps, when the heart's filling back up, the blood pressure lowers because there's not that pumping force, and that's the bottom number.
So normal can also be different for different individuals.
Right. even though, right, so for instance, a younger person, it's not uncommon to see systolic or upper number blood pressures of 100 or even as low as 90. In somebody with who normally has a high blood pressure, you see a blood pressure of 90, you say, gee, the blood pressure dropped from 140 down to 90. That's a big drop. Somebody's going to feel that. On the other hand, young people, athletes, may run a systolic blood pressure between 90 and 100, and their body is used to that because all the other systems are working, and that's all they need to perfuse, to get blood flow to all of their organs.
And does heart rate correlate to any of that?
The body, heart rate, if the body's a complex machine, so it's the simplest way of thinking of the circulatory system is a pump and a hose. But there's things that can happen. The pump can, go into second gear and third gear where it can pump harder, so to speak. It can pump faster. The blood vessel can dilate so that there's less pressure inside. It can constrict. So both these things are happening at once. So if you keep everything equal and the heart pumps faster, then yes, the blood pressure would go up. But usually in somebody who's exercising, if their heart rate goes up, the body's going to compensate so it's not dangerous to exercise because the body has other ways of compensating for it.
So let's say kind of a step back, and let's say you have a patient come in either as an outpatient to an office or through the emergency room when they don't really know what's going on or what it is. And obviously part of the vital signs, which is important to take initially, things like blood pressure, heart rate, and temperature, blood pressure is part of it. How do you sort of work this up, or how do you deal with the patient? What do you ask him about different types of symptoms? So
let's go with the patient who hasn't been to the doctor in 10 years. They lost their health insurance, they're too busy with their job. These are common things, although doctors and public health people would like people to get their checkup every year. It doesn't happen all the time. So you come into the office, and let's say you're 40 years old, because higher or borderline blood pressures before age 40, they're going to cause damage in the long run, but the studies are really what happens if your blood pressure is this level when you're 40, what happens from there on. So you're otherwise fairly healthy, had no medical problems, and your doctor says, your blood pressure's 150 over 80. And immediately you're thinking, oh, I saw this show on TV, they said it's the silent killer. Doc, am I going to be okay? Well, the good news is silent killer, has all kinds of connotations. Blood pressure does its damage over time. You need 20 years, 30 years sometimes to have the blood pressure lead to a death, let's say. But the sooner you treat it, the better you're going to do in the long run. So you don't need to worry. 150 over 80, yes, that's a high blood pressure. So then the first thing the doctor should do is recheck it. Sometimes, if you ran in from your car, late to the doctor's appointment, you sit down on the table or you sit down in the chair, the blood pressure